Welcome, ladies and gentlemen, to another session of the WNS Operative Round. Our today's guest is Dr. John Tu from Mayfield Clinic and University of Cincinnati Neuroscience Institute. He's a master surgeon. He doesn't require any introduction. He has been a great mentor for many young neurosurgeons, including myself. He will be talking to us about indications, rationale, and technique and outcome for percutaneous procedures for trigeminal neuralgia with a specific emphasis on radiofrequency rhizotomy. Dr. Tu, thank you for joining us, and please go ahead.
Okay, Aaron, how are you? Thank you very much. We're going to start the discussion by looking at the first slide, which discussed the treatment options. Of course, everyone knows that medication should be tried first for trigeminal neuralgia, and we will focus principally today on the surgical approaches that are what I prefer to call ablative versus physiologic. Ablative procedures are largely done percutaneously, either by radiofrequency, injection of glycerol, balloon compression, or occasionally radiosurgery may be used also. Physiologic procedures where you do not cut a portion of the nerve or destroy a portion of the nerve by some type of physical measure are called physiologic in my example that we're talking about today. And that, of course, is microvascular decompression. Choosing the treatment is very important. So we talked about the physiologic, which is microvascular decompression, and we'll focus most of our attention today on percutaneous radiofrequency treatment and glycerol or balloon compression with a preference for balloon compression. Radiofrequency, as you know, is a selective procedure that uses a heating current. It's kind of like microwave. It's a 1 megacycle current, and it selectively has the capacity to interrupt nerve fibers in various divisions of the nerve root. Glycerol injection does a destructive procedure also, but using alcohol, and it unfortunately is not a selective procedure, and it requires that one get into the cistern and achieve a flow of CSF. So in many cases where there's been previous treatment, there may not be the possibility of getting CSF flow. Balloon compression is a very good procedure for certain cases, and it will be, of course, discussed in more detail by Dr. Cohen. It's preferred by some people because it doesn't require the type of testing that is needed or essential and very helpful in using radiofrequency. But it does allow you to compress the ganglion and some of the posterior root of the nerve and produce a selected lesion. In my experience, I prefer percutaneous radiofrequency for these types of circumstances. Of course, when there's been a failure of medical therapy, when the patient has major medical comorbidities, a failure of previous MVD. I don't think there are many indications to repeat a microvascular decompression because the results are less good on the second occasion and the complication rate is considerably higher. The patients who have pain in the first division alone are not good candidates for radiofrequency because there is some risk to the corneal sensitivity. But unfortunately, that is something that we don't have to deal with very often. There's another example of a high indication in my experience, and that's patients with trigeminal neuralgia associated with multiple sclerosis. These patients are very severely affected by the condition, and many times they have comorbidities that make more complex operations difficult. So radiofrequency is a very good option for them. And of course, always patient preference. Patients come to me frequently wanting to have a percutaneous procedure because they've heard about it and don't want to have a craniotomy. But we try to talk them into having the best procedure for their condition. But patient preference is always something to take into consideration. We're going to talk about the 6 steps that we go through in doing a percutaneous procedure, whether it's for radiofrequency or for balloon compression. You would do many of these steps for either of these procedures. The first one is, of course, to prepare the patient for the procedure. Use a fluoroscopic C-arm, and in balloon compression, one would use an anesthesiologist and use a general anesthetic, but in radiofrequency, we just use a very short-acting or ultra-short-acting barbiturate called methotrexate and inject 0.5 milligram per kilogram. So that's, in general, very effective. We've tried another group of drugs, but find that methotrexate is by far the most effective. So the patient is placed in the radiology suite, or it can be in an outpatient operative facility. That's where we do most of ours now. And it's very important that they be awake and receive only preoperative atropine, about 0.4 milligrams, so that they are able to wake up very quickly in between procedures. So you outline the landmarks which allow you to place the needle exactly into the foramen ovale. One is the medial aspect of the pupil, 3 centimeters anterior to the external meatus, and 2.5 centimeters lateral to the commissure. So we've placed these marks on the patient every time, even though we've done thousands of these operations. Then the fluoroscopic setup is used, and this is a technique that we developed, and we discovered that you can use the lateral fluoroscope very effectively to guide your needle in place. So you want to see a good picture that defines the clival line, and your trajectory is going to be sighted right toward this point. We'll talk more about that as we go along. So you cannulate the foramen ovale by placing your finger along the lateral aspect of the pterygoid and guide the needle along that trajectory. We'll show more about this as we proceed. You angle that cannula toward the intersection of those 2 lines, one going from the tip of the nose toward the external canal, and the other angle toward the medial aspect of the pupil. We'll keep coming back to this point. This shows it on a dry skull, how you guide your needle there with your fingertip. It's important to use a dental prop in the mouth so that it keeps the patient's mouth open and prevents them from inadvertently biting your finger during the course of this operation. So you see how it's guided right to that medial aspect of the foramen ovale. And that's important for a reason that we'll talk about later. So you use the lateral fluoroscopy, and you're looking toward this point about 5 millimeters to 10 millimeters below a plane that intersects with the profile of the clivus and the floor of the cella. So, Dr. Cohen, can we see the first video, please? So this is another video actually done on a dry skull, and you can see the fluoroscopic image of the needle being following the correct trajectory. So if you just make a fluoroscopic image right at this point, you can see exactly where it should be going. So let's see the next video, please, Dr. Cohen. So here we are actually doing a patient, and you see the block going between the teeth. The nurse anesthetist will inject the Brevitol, and when the patient is adequately anesthetized, which takes less than 30 seconds, the cannula is placed and the surgeon is guiding it in place. And here you see the lateral fluoroscopic image showing the placement. And within another 30 seconds or even less, the patient is awake and cooperative again. Just reviewing the tips. The best target is the medial anterior aspect of the foramen. The trajectory contacts the malar ridge just anterior to the foramen. So then you take a look with the fluoroscopy, and then you slip the needle into the foramen just along that trajectory that you see here on the screen. There you go. Okay. Now, of course, there are some things to be concerned about: the carotid artery, the inferior orbital fissure, and the jugular foramen. 3 areas that are important to keep in mind. 4 is a trajectory way up here. That's why the lateral fluoroscopy is so important. And 3 is the carotid artery. All along here is 2 is an area, and also 1 where the carotid canal begins at the foramen lacerum. And 5 way down here is the jugular foramen. So on this dry skull, you can see inferior orbital fissure. There's the foramen ovale, foramen lacerum, jugular foramen, and the carotid canal. So you have to keep your needle right here. You want it to slip into the foramen ovale right at that point. And using that lateral fluoroscopy, it is very helpful in getting you to that trajectory. Okay, so this is a simulation using MRI. It might be helpful to you, but it just shows you in 3 dimensions. First the axial, then the sagittal, and a coronal, how it progresses. So if you will run the video now, you can actually see what the needle passes through at the simulation in 3 dimensions. So it's going along this trajectory toward the foramen ovale. You see it passing through right here. It may be helpful for those of you who are watching to repeat this a few times, but you can see your end point, your trajectory is the foramen ovale and the trigeminal cistern right here, and of course the posterior root of the trigeminal nerve. And we'll show that again in other slides that will help you understand that situation. So coming back to the slides, this is your trajectory right here in the lateral view. So you can see exactly how it outlines 5 to 10 millimeters below this point along the profile of the clivus. And in most circumstances, you will get CSF. If you don't, it still can be a very successful procedure. You don't have to have CSF, but it usually indicates that you've reached the cistern deep to the ganglion. And the fibers of the posterior root are organized thusly: third division, second division, first division. So we'll show how by a use of the curved electrode, you can selectively stimulate and cannulate each of those fiber groups. It requires frequently an advancing of the electrode to reach the first division. But because we want to spare the first division in most patients and not create a lesion there, we don't go into that area. So these are guidelines. This is an artist procedure, but this is generally how it works. So you see the ability to manipulate that electrode by pulling it back in and tilting the electrode upward, downward, medial, or lateral. So the patient is awake when you use the stimulation, and we start with a low current to titrate the current up, and you have very good patient interaction in order to get good communication and collaboration. So you should get a stimulation usually around 0.1 volts. If it requires a large stimulation as much as a volt, that means that it's not going to be successful because the electrode is not in the exact relationship with the trigeminal roots. That's why we enter the foramen ovale on the medial anterior aspect. So you see here, the electrode is placed inside the cannula. And we begin by stimulating. There's a fluoroscopic view showing exactly where the electrode is located. Now the patient will hear us asking questions about where they feel the electrical shock. So this patient says on the video that she feels it exactly in the mid portion of the face. So that's exactly where we want it in her case. And you can see that she's having a little bit of pain that indicates that we're reproducing the pain with the electrical stimulus. So that's how we know that we're in the correct division and that we're getting a very good localization. So once we get that response, we put the patient back to sleep and make a therapeutic lesion. When patients are having severe trigeminal neuralgia, the stimulation may actually bring on an attack. So they have to be very careful about using a low voltage stimulation during this part of the procedure. And of course, that's a concern with having the patient awake. This slide shows how we equate the intensity of the stimulation with the probe temperature that we would use to make a lesion. The more stimulus required as the voltage increases, it means that more temperature, which you're recording the temperature while you're making the lesion, is appropriate. So we never take the temperature above 80 degrees centigrade. That's just under boiling, or under the point where you would make a irreversible lesion and actually coagulate the tip of the electrode. So these are the primary areas you want to work in, around 70 degrees centigrade. So to produce a lesion, of course, put the patient back to sleep, measure the temperature, and then after awaking, you monitor the sensory findings. And we do that by awaking the patient again, comparing the opposite side, the right to the left, sharp to dull, and crossing over the midline. And the patient, being awake, can carefully and very effectively identify the degree of the sensory loss, whether it's hypalgesia, analgesia, or anesthesia. Of course, you're seeking to get just a hypalgesia or marked hypalgesia. And we'll see in a moment how that is done. So let's look at the video now, please, Dr. Cohen. So using a sharp, you watch how the patient reacts when you reach the midline. You can see that, so she is identifying it as sharp in the forehead and much less sharp in both the second and the third division. And you also get the visual hint by watching the patient. And then the patient can compare the two sides. So what we've learned here, that we need to make a little more lesion because the patient is sharper than I would like to see her in the second division. What she's doing now is actually quantify the lesion, telling you it's 50% sharp in the second division, about 80% sharp in the third division, and 100% sharp in the first division. It's a very cooperative patient who helps us a lot with the procedure. So tips on lesioning: you reposition the electrode if you need to, stimulate again, and your testing should always be done in the autonomous zones. If you get into zones where you may be getting some innervation from other areas, as is true over the nose or right in here. So the autonomous zone for 1 is right above the eyebrow, 2 for underneath the eye, and for 3 is the lower lip, slightly away from the midline. So let's look at the lesion testing one more time. So this is the type of, she's telling us that it's normal in the first division. And markedly hypalgesic in the second division. Okay, let's go back to the slides, please. Now, this is just the final testing to confirm that the patient has normal motor response in the trigeminal nerve, normal visual tracking, so no cranial nerve deficits of 3, 4, or 6, normal motor, and she's discussing the procedure, and she actually says, if you could hear her, it was not painful, and she doesn't remember most of the procedure. One of the nice things about the methotrexate is it creates an amnesia. So there are some complications, temporary jaw weakness, and these are temporary signs. Absent corneal reflex in about 3% of patients, temporary diplopia 1%, inflammation of the cornea, and as in all procedures that are destructive, you may get patients who have anesthesia dolorosa. So, but partial facial numbness is not a complication. It's a titrated endpoint. It's an expected outcome necessary for pain relief. Patients have tolerance for facial numbness. Most of them do not find it disturbing. There are rare, mild disturbances, and occasionally patients are troubled a lot by facial numbness. So you have to be very careful not to produce too much sensory loss. And that's one of the advantages, of course, of less destructive procedures. But a principal advantage of this technique, well done, as shown in this case, is you can calculate the degree of numbness. And as you see here, the degree of numbness is directly related to the long-term effect on relief of pain. Recurrence is much higher if you have mild sensory deficit than it is if you have major sensory deficit. But it's still a very reasonable procedure to do, particularly in patients who don't want to have any significant numbness. So the observations that I would say for treatment with all patients with trigeminal neuralgia, first is you need to be absolutely sure about the diagnosis, that you're dealing with trigeminal neuralgia, that it's not atypical facial pain. And of course, the characteristics associated with the diagnosis are well known to most patients because they've become very familiar with it. But with the passage of time and long usage of medication, and sometimes even with other treatment, they forget what it was like in the beginning. So it's very important to go back and take the original history. And in order to be successful with the care of any patient, it's important to be optimistic and obviously a good listener. Perhaps one of the most important things we can learn is that there is no cure for trigeminal neuralgia. Every procedure that we use has some failure rate. So you want to use the best procedure for each patient to be individualized. And Dr. Cohen will speak to that in detail when he discusses the technique for doing compression technique with the balloon. And unfortunately, dysesthesia occurs with all ablative procedures. And the more numbness you create with any procedure, the more likelihood there is for development of unpleasant sensation called dysesthesia. Unfortunately, dysesthesia is not responsive to additional ablative procedures, so that's important to remember. And it's essential to know, I think, that the outcome of treatment worsens with chronicity. The longer a patient suffers, the longer they take medication, the more likely they are to have a less effective result. And in my experience, some may disagree with this, but repeat MVD surgery certainly has a higher risk and less opportunity for success. So that's one of the reasons percutaneous procedures are important. to have as a part of your curriculum and in your program. And I know at the University of Indiana with Dr. Cohen, he does a lot of different procedures and can offer the patient virtually any type of technique, whatever is best needed for their type of pain and condition. So maybe we should talk a little bit about that, Dr. Cohen. I appreciate your thoughts on that topic or others.
Dr. Chu, thank you again for really great nuances in terms of both selection and the technique. If you don't mind, I would like to echo some of the important points that you very eloquently mentioned. Number one is trigeminal neuralgia has no cure, and the patient should understand that from the beginning. Also, patient selection is the most important factor in the ultimate outcome. Patients should have good cutaneous triggers. Having some constant pain does not exclude them based on virtual classification, which I recommend our viewers to review. And the character of the pain can change with medications and previous percutaneous procedures. So initial history taking or really reflecting back how the pain was at the beginning is very important. Most importantly, very young patients, younger than 40 years of age, when they have trigeminal neuralgia, you really have to have a request a complete workup to rule out multiple sclerosis or other reasons for their pain. As we know, it's really unusual to be very young and have typical trigeminal neuralgia. Let's say those are the pearls for diagnosis. When we come to selection, I think both you and me agree that microvascular decompression is the best way to go for most patients if they can tolerate surgery and they have typical trigeminal neuralgia. Again, going back to the diagnosis, if they have burning pain, if the pain does not have cutaneous triggers, and if the pain is in atypical locations in the face, that really brings up very red flags that the patient may not do well with any procedure you choose. But let's say the patient is young enough, they have typical trigeminal neuralgia, they're younger than 70 or 75 years of age. I would say both you and me agree that microvascular decompression is the best approach. Do you agree with that?
Well, let me ask you one question about that. So we are very blessed today having excellent imaging techniques. So if you do a specialized imaging like the Fiesta protocol and you don't see any evidence in a very good high resolution MRI of vascular contact, so the SCA or other arterial loops are nowhere near the nerve, would you recommend an MVD for that patient, or would you consider a destructive procedure like balloon compression or radiofrequency?
Yeah, that's an extremely good question. You know, I would say if the patient is really healthy and they're relatively on the younger side of the age for trigeminal neuralgia, I still would go ahead and explore the posterior fossa because I have had patients that even on Fiesta, they may have had no vessels, and we did find vessels intraoperative. However, this would be another factor in the big picture that would lower my threshold for offering them an MVD if they're older. If there's any question about their pain that is not typical trigeminal neuralgia. Again, decision making is not based on one factor, it's many factors which would lead us believe what's the right choice for the right patient. And as you very well mentioned, that's just one factor in the pool. You can't just define that, well, this is how every patient should be treated. There is an art to the practice of treating trigeminal neuralgia, but I would say if the patient is on the younger side for the ages of trigeminal neuralgia, which is, let's say, 55 to 80 years old, I still would consider MVD. May I ask what your thoughts are in that situation?
Well, my opinion is that virtually anyone who is not anticoagulated or who doesn't have to be maintained on anticoagulants can have an MVD. In fact, older patients who have some relaxation of the cisterns or have more cerebellar atrophy are actually easier to do, and they do extremely well. So physiologic age is very important. I wouldn't rely any significant consideration to chronologic age because the procedure is so well done by experts, and certainly you are one of those.
Thank you.
Who can operate on virtually anyone with a good anesthesia team and get a good result, with the caveat that there is some evidence of compression. On the other hand, if the older patient has no evidence of compression on the image, I would use a ablative procedure.
Let's say we decide that the patient should go under microvascular decompression and they do well. That's obviously a separate category. Let's now focus on patients who are a good candidate for a percutaneous procedure, either because they're not a good fit to undergo major surgery like, not a major surgery, but MVD, let's say, or because they're older or they prefer to do a percutaneous procedure, or they have multiple sclerosis, which, as we know, they're not necessarily a good candidate for microvascular decompression. I know you have been a pioneer in radiofrequency rhizotomy. I do the technique exactly like you described it, and it works beautifully. There is no doubt it has made a huge difference in the lives of many trigeminal neuralgia patients. The way I have looked at it, if a patient is a candidate for a percutaneous procedure, I either do radiofrequency rhizotomy or balloon compression. I'm going to review at the end the advantages and disadvantages of each, but maybe this is a good time before we go to the video we can review those. I like radiofrequency rhizotomy because it's very selective. It definitely targets either V2 or V3, and you can immediately get a feedback that you did the job. In other words, the patient has numbness, very mild one, where you need it to be. It is somewhat milder than balloon because the balloon is a little bit non-selective. So I would say radiofrequency is a very effective procedure. What I'd argue against the radiofrequency rhizotomy is that, number one, sometimes patient comfort can be important. And even though most patients have amnesia, if they are somewhat demented, if they can't tolerate pain of any capacity, if they're not cooperative for other reasons, they may not be a great candidate for radiofrequency rhizotomy. Number two is, what about a patient who has a V1 trigeminal neuralgia? I think balloon is an excellent procedure, or a glycerol rhizotomy. Number three, which I would like to ask your opinion, what about if the patient who has trigeminal neuralgia in all three divisions? How would you argue about those points that are disadvantages of radiofrequency rhizotomy?
I think your points are very well taken. If you have isolated pain in V1, so that's 1 or 2% of all patients, one thing you can do is just a peripheral neurectomy. And many of those patients do extremely well with that simple procedure. If there are 3 division pain, I think percutaneous balloon procedure is a very reasonable option because you get all 3 divisions and you spare technically the sensitivity of the cornea. So in my understanding, I would certainly agree with you. It's a very reasonable option. I think another example would be patients with multiple sclerosis. So balloon compression is a very reasonable option if all 3 divisions were involved. But you want to be sure in those patients that you don't create too much sensitivity loss, because they may have pain develop on the opposite side. So I certainly agree with you that every center, everybody who has an expertise in trigeminal neuralgia should know how to do one or both of these ablative percutaneous procedures.
Now that we talked about the decision-making process for microvascular decompression or a percutaneous procedure, I think there are a group of patients who are a reasonable candidate for radiosurgery rhizotomy. And although I personally have had a less effective response for radiosurgery rhizotomy, I'll do all three procedures. I feel that the efficacy of radiosurgery is about 60 or 70% of the patients, and it's definitely less than microvascular decompression and a percutaneous procedure, especially if the patient wants to come off of their pain medications. Therefore, unless they have significant medical comorbidities that prevent them from undergoing an invasive procedure, I have gone either the route of MVD or a percutaneous procedure. Is that been your experience, or it's been otherwise?
I think about the only real indication for, well, there are two indications for radiosurgery. One is the patient, in the opinion of their treating physician, cannot come off anticoagulants, or even for a reasonable period of time, 48 hours or whatever, to allow them then to go a percutaneous ablative procedure. And the second is patient preference. And there are some people who just don't want to have any type of invasive procedure. And of course, either of the procedures that are done with needles are invasive, and there are some individuals who don't want to have it. There's definitely a place for radiation. I think it's very small. My criticism is that too many patients get radiosurgery, even for conditions that they should never have it for, like shingles and postherpetic neuralgia and all kinds of things. But I fear because it's too easy. It just doesn't require the type of technical skills it takes to do a balloon compression, for example.
Have you been using radiofrequency rhizotomy for postherpetic neuralgia since you brought it up? That's a very complex topic of its own.
No, I would definitely not recommend or ever consider doing a percutaneous ablative procedure of any sort for postherpetic neuralgia.
I agree with you completely. If you don't mind, I'm just going to review a few nuances that has worked for us. Probably is going to really echo what you very well mentioned. And then we're going to review a video of a balloon compression rhizotomy and get your opinion about that technique in general. Remember, the advantage of the balloon compression rhizotomy potentially over radiofrequency is that patient comfort could be more because the patient is done under anesthetic. It is a much, at least in our hands, is a faster procedure. It takes us less than 5 minutes from the moment we penetrate the skin. And we have had very good outcomes without necessarily too much numbness or other complications from significant ablative techniques on the nerve. So I'm going to review some of those with you and again get your expert opinion. I think the setup for the room is very clear, and you reviewed them very eloquently. I would like to take a moment and just emphasize the importance of fluoroscopy. You mentioned that the lateral fluoroscopy is critical, no doubt. Nobody should do this procedure without fluoroscopy. What we have used is by extending, besides using lateral fluoroscopy, is also using the fluoroscopy through the or parallel to the angle or axis of the needle. In other words, you have the fluoroscopy arm turn, you extend the neck of the patient and the head, and you turn the head contralaterally. And this gives you a bird's eye view through the needle for us to be able to see where we are compared to the foramen, and has really been very, very effective in giving us another, let's say, confidence factor to make sure we're close to the foramen. Because even though lateral fluoroscopy gives you an AP and lateral correction, the accurate lateral to medial trajectory can be somewhat confusing, especially in patients with a very small foramen, or those patients who have a sort of a ridge, a bony ridge in the foramen. So, and I'll show you in the video what the picture looks like. And I want to emphasize this technique for our readers, especially for those who are novice neurosurgeons at this technique, that using another localization technique can be quite effective in getting the needle in there. So the 2.5 centimeter rule was very well mentioned by you. Obviously, this is a radiofrequency needle described by yourself and invented by yourself. And then, as you can see, the needle is along the medial edge of the foramen for a good contact to the nerves of the trigeminal nerve, so, or the roots of the trigeminal nerve. You can see obviously the degree of angulation and the distance from the sella. Those were well mentioned by you. I think the angulation of the needle, those are all reviewed. And so after this is done, obviously the patients go home same day. There's no need for inpatient hospitalization. And one of the details about a glycerol rhizotomy, which I have personally not used, is the need for a sitting position. I think glycerol rhizotomy may have potentially slightly high risk of pain recurrence, although when you read a lot of different studies, there's never been a randomized trial, there's never been a clean study to compare percutaneous radiofrequency rhizotomy to a balloon compression to a glycerol rhizotomy. So we don't have ultimately the clean data that could tell us which procedure is better. But overall, what has been my practice is I start with a balloon compression rhizotomy. Sometimes patients don't get relief, and that could be that their Gasserian cistern is very large and the balloon just cannot sit in the right position to compress the Gasserian ganglion, or the fact that it's so tight that I cannot even inflate the balloon in the cistern. Therefore, I'll bring those patients back with a radiofrequency rhizotomy, and we have had a very good results. And again, you have to gauge what works for you and stick with it. Do you have any comments before we go to the video, Dr. Chu?
No, I agree with your approach, except I only use the lateral fluoroscopy. And using those techniques that I described, it's very easy to get into the foramen. And also in this medial anterior part. But obviously, I have a lot of experience. So if the individual feels more confident using an oblique view with the fluoroscopy, I think it's perfectly okay. I certainly don't think you need to use a stereotactic system or an MRI like some people have recommended.
Yeah, I agree. So let's go ahead and review this video. I want to make a differentiation that the balloon compresses the Gasserian ganglion, so it's at the level of the ganglion, or radiofrequency rhizotomy is at the level of the roots of the trigeminal nerve. There is a big difference between the two. So if you put your needle over radiofrequency and you're not exactly at the level of the root and you're more distal, you may actually get an exaggerated pain response, and it tells you that your needle is not at the right position. So let's talk about percutaneous trigeminal ganglion balloon compression rhizotomy. In a case of a 72-year-old male with a V2 and V3 trigeminal neuralgia, the setup for the room is very classic. Again, we emphasize the importance of fluoroscopy. And you can see in this video we use a ruler to measure the distance of about 2.5 centimeters. We stab the incision to create a nice entry for the needle of the balloon, which is larger, and then we obviously make sure the needle does not perforate the mucosa medially. And then we go ahead, and as you can see here, I just hit the angle of the mandible to make sure I'm on the right trajectory, and then I angle needle more medially, and that gives me another view of how things are in relationship to the foramen. You're going to see momentarily, we're going to have an overlay view of the skull, which will give us an idea where things are here. Again, passing the pterygoid. And here's the view of a surgeon if you have a skull. We wish every patient had this sort of view and with their skull overlaid on their head. And you can see for a surgeon how the angle is. It's again medial canthus, just like you mentioned, and it's 3 centimeter anterior to the ear. And that's the view, so you want to have that in mind as you're advancing your needle. Obviously, you don't want to hit the carotid artery or the jugular vein to avoid any complications in that area. So we'll go ahead and again feel the angle. We'll go ahead and place the needle, and we'll go ahead and do a lateral fluoroscopy. And in this situation, you can see that again I pointed it where the clivus and the petrous bone meet each other. That's really where we want it to be. And after I get that lateral view and gives me an idea of my anterior and posterior trajectory is satisfactory, I'll go ahead and do the oblique view through the fluoroscopy that you very well mentioned, which would give me an idea. As you can see, here's the fluoroscope moving in a new position. The patient's head is turned contralaterally and extended, and here is the view of how the fluoroscope should look parallel to the needle. And here you can see the foramen clearly. There's no way you can miss it, especially in this case. And it tells me that I have the right anterior to posterior trajectory, lateral to medial trajectory, but I'm a little bit posterior to the foramen. So I just have to advance my needle just anteriorly and maybe slightly medially, and I'll be right in the foramen. And here is after repositioning of the needle. And you can see on the second view of the fluoroscope, in the oblique view, that I'm definitely in the foramen. There's no doubt about it. There's no questions. It really is a confidence builder, especially for the beginners, that they're definitely in foraminal valley. Here is advancing through the foramen across the skull base. I usually bring the needle backwards to be as close to the skull base as possible, as you can see here, because I don't want my balloon to be inflated over the petrous ridge. And here you can see CSF. That's always a nice confirmation that again I'm where I need to be. We pass the stylet to create the pathway for the balloon, which is obviously deflated in this situation. We go ahead and advance the catheter and go ahead and inflate the balloon under live fluoroscopy or getting multiple images at the same time consecutively. And you can see the balloon gets inflated, and you can also appreciate almost this sort of little indentation, or you say elevation, that tells you that's V2. So we're right where we would like to be. We're in Gasserian cistern. You can see sometimes the balloon can go over the petrous ridge if it's inflated too much. But here is really V2 as it enters the foramen, and obviously we're in V3. So that's a nice placement of the balloon. I have to emphasize that if your balloon is too high, it's going to go over the petrous ridge, and you will not get a good balloon compression for the Gasserian ganglia. And that's really critical. The shape of the balloon, there's been multiple studies there. You don't want to be too high. That would also potentially can cause double vision by compression of the nerves in the cavernous sinus. You want to be as close as to the skull base as you can, but not too close that necessarily your balloon would not inflate. And we usually inflate the balloon for about a minute and a half, and then it's deflated, and x-rays performed to assure that everything is deflated, and then the whole apparatus is removed, and we're done. Really 5 minutes. Patient is asleep, very comfortable, and we have had very good luck performing this procedure with minimal complications. So if I may ask you, to have the closing statements, Dr. Tu. Again, I appreciate your time.
Okay, well, I think we have a very nice discussion here about techniques that are available, that there are essentially two techniques, ablative and physiologic. And we all know that we want a physiologic procedure if we can achieve that and if it is the best in the interest of the patient. In choosing an ablative procedure, I think we have lots of options, but we agree that a needle procedure is preferred, and there are two extremely good options, either radiofrequency or balloon. I personally prefer to use the radiofrequency first rather than the balloon because I think it's a more, I would say, a little more selective procedure that allows you to get a single division or two divisions, which is the circumstance in most patients. The majority of patients, 65 to 85%, have pain in either the second or the third division or both. So it's a very nice technique. It does have the disadvantage of requiring or utilizing patient collaboration. That's an advantage and a disadvantage, whereas the balloon compression procedure is not selective, allows the patient to be asleep. So there may be some patient preference for that. In terms of timing, I think I can do a percutaneous radiofrequency in 15 minutes. In fact, I can do 7 in an afternoon with the turnover. So the timing or the amount of time required to do it is not an issue, but certainly there's no question that it does take more, I'd say, experience and more study to do it well than a balloon compression. But obviously, as you pointed out, you've had a lot of experience and you know exactly what to do. I wonder if there is any concern about hitting the carotid or the cavernous sinus, or are there any serious complications that might occur with this procedure? Of course, some of our colleagues have had some major problems with the placement of needles for radiofrequency, such as carotid injuries and aneurysms formation and even carotid cavernous fistula. So there are some serious complications with all of these procedures, but as you have outlined it and we have discussed the careful procedural techniques, I think it has a very, very low complication rate and a high level of patient satisfaction with both of these procedures.
I agree with you. I've done about 300 of these percutaneous procedures so far, and I can tell you that I have hit the carotid artery once, and it's very dramatic. There's no question the flow of the blood would shock you, because especially we've never seen it before. And we just withdraw the needle and woke up the patient. The patient was intact. We did a CT angiogram to exclude a fistula or a pseudoaneurysm and repeated another scan in 2 weeks, and the patient did well. And miraculously, her pain went away as well, and that probably was because just entering the foramen, you injure the nerve, and that was just good enough. So as I've always said, and Dr. Roberto Harris once told me that the best quality of a surgeon and the most important thing, number one, is to be lucky. And I'll tell you, I have been lucky personally, and that was a pretty dramatic case of hitting carotid artery with the needle. But that's a risk with any percutaneous procedure. I don't think you can rationalize that, balloon has more than radiofrequency or radiofrequency than balloon. But you have to understand, if you do enough of these, you will surely have complications.
Okay, great, Dr. Cohen. This has been a lot of fun. I think anybody who studies and works on this video and this study that you put together here will appreciate the opportunity to learn. One of the reasons I like to do this with you is it creates a procedural opportunity for people to learn how to do these techniques. You obviously put it together very nicely, and so individuals have no excuse now not to learn how to do these techniques and to incorporate it into their practice. So thank you very much.
Dr. Tu, thank you for being a great mentor for so many of us, and truly thank you for what you have done for neurosurgery. Thank you again.